Good afternoon, everyone.
Welcome.
Morning.
Oh, go ahead. Oh, hi, Dr. Foster. Great to see everyone. We'll give everyone another minute or so to get connected, and then we'll get started.
Hey, honey, which day, Doc Foster?
Okay. All right. Well, I think we can go ahead and get started. I'm just going to pull up our slides here and do some introductory information. 1 second. Okay. So I want to welcome you all. My name is Kate Trams, and I am with the National American Indian and Alaska Native Addiction Technology Transfer Center. I'm here with Steve Steine, and he is our program manager for the center, and he is going to be presenting on professional and ethical responsibilities today. We are part of the ATTC network, which is shown on this slide, our map of the 10 regional centers. We also have a network coordinating office and the National Hispanic and Latino ATTC. We want to let you know that CEUs are available for this session. We will be sending an email to everyone who attended, as well as everyone who registered. If you attended, you'll get an email with the recording, handouts, and then you can just reply to that email if you'd like to earn CEUs for this session. And if you ever miss a session, it's always a good idea to register, because you'll also get that link to the recording and handouts even if you don't attend, so you can view it later. We do have a short survey that we are gonna put a link to in our chat at the end of our session today. This will just let us know what you think about this session, and it'll give you a chance to give us some feedback. We really appreciate you letting us know what you think of this session. And I do want to throw out there that while most of our programs try to be very culturally informed, this particular series, our Essential Substance Abuse series, was created to help people pass their alcohol and drug exams. And so it isn't as culturally informed as many of our other projects, because it's based on the exams that most states have, which are obviously not culturally informed projects. But we always welcome discussion and questions about how these relate to Native culture, how these practices relate. And so I just wanted to welcome your questions and comments about that too. We'll have time for that at the end. Just if you've never used Zoom before, please note that you can open up the chat box. There should be a button on the bottom of your screen to open that up, and it'll show up on the right side of your screen. You can put in questions and comments there anytime. And then we will have time at the end if you'd like to also unmute yourself and ask a question. We'll have a designated time for that at the end of the session, and maybe one somewhere in the middle too. So we would love to have you be part of the conversation and share your thoughts with us during that time too. So I want to introduce Steve. Steve Steine is our program manager for the ATTC, and he has been working in substance abuse counseling since 1997. And he was born and raised in Iowa and has been in behavioral health services and in the nonprofit sector for the past 23 years, providing direct patient care as a clinician and providing supervision as a clinical manager. He's also been in recovery for over 32 years and has committed his life and his profession to helping others in the recovery process. So I'm so glad that we have Steve to share with us today. So I'm going to stop sharing my slides, and Steve's going to pull them up on his end. And just want to say thank you all for joining us. And thanks, Steve, for sharing your knowledge with us today.
Well, thank you, Kate. Let me see if I can get my slides up here and avoid the technical difficulties we had last time. Let me see if I can pull up the proper slide deck here. Sorry, Kate, I thought perhaps you would advance those slides for me, but let me see if I can get mine up here.
I can do that otherwise, Steve.
Oh,
Just, you know.
yeah. What that might be better for me if you're willing to advance those slides for me, then I can. I do have multiple screens going, so that's going to help me a little bit more too. So I can watch the chat box, and Kate and I will try and field questions as they come in, and hopefully we'll have a chance to have a little bit of a dialogue. I know it's a little harder to do in. I might actually move this over here so I'm looking at you guys instead of. Now I'm too dark. Let's see if we can. I'm just trying to get my screen moved. Okay, here we go. Now we're back. Okay. Now we get this adjusted again. Pay no attention to all my secret plans on the whiteboard behind me. Those are highly sensitive and very top secret. So please don't take any screenshots of those. That's in case the whole system goes down. I'll have everything on my whiteboard. I don't know if anybody can relate to that, but it's my backup plan. It's like my cloud drive, it's on the whiteboard. Great to see everyone. Great to see some familiar faces and names. Really glad that you decided to join Kate and I for the next hour or so. We've got a lot to go over, and I'm really hoping that for many of you this is going to be a review. For some of you it may be information that you are coming across for the first time, or perhaps haven't had a chance to really give much thought to or reflect on. So I'm hoping that we have a chance to review, for some of you review, and for others to think about how this applies to the work that you do. So before we begin, I just want to take a couple of minutes to just have everybody just take a few deep breaths and kind of clear your desk or close other programs down, and let's just take a few minutes to center ourselves and get ready to exchange some ideas and thoughts and information. Okay. And I know some of us in the Midwest are still recovering from the storms that came through last week. So if you've been affected by those, I want to just send out my thoughts and well wishes to you. We do have power back here now for most of us, but there are still a lot of communities in the area that don't have any power. So my thoughts go out to them as well. I'm really hoping today to talk a little bit about, and I want to put it in sort of context with the work that you do in the helping professions or related to behavioral health. And I want us to think about, we're going to talk a lot today about ethical decision making. We're going to talk about confidentiality and how that applies. And I think it's really important, especially in the mental health and substance use disorder fields, that we really place an emphasis on confidentiality and protecting the rights and privacy of our patients. So that's going to be a theme that you'll see continue to come up during today's discussion. As Kate said, my name is Steve Steine. I work here at the National Addiction Technology Transfer Center, American Indian Alaska Native Center for Behavioral Health in Iowa City. So I'm broadcasting to you today live from Iowa City, Iowa. on the University of Iowa campus. I've been employed here for the last year and a half, and prior to that, I spent over 2 decades working in a clinical setting, substance abuse, mental health, and other behavioral disorders. I am a certified addictions counselor and have my master's degree in counselor or substance abuse counseling. So really glad everyone's here. Let's look at some objectives for today's webinar. We're going to really, the first thing we're going to look at, as I mentioned, I want to look at some ethical principles. I want to look at autonomy and non-maleficence, beneficence, social justice, fidelity, veracity, and I also want to take a look at we're going to briefly review 13 principles of effective treatment. We will look at some professional codes of ethics, and then also some ethical responsibilities as they apply to the code of ethics, patient rights, mandatory reporting, boundary issues, and the utilization of supervision, which I think is also really important for those of you that are overseeing or managing a staff right now. So let's advance the next slide. So some kind of key words to think about, and again, I think some of these will be things that you've already given some thought to or are utilizing in your day-to-day practice and work with others, either patients or other clinicians or practitioners. But some words to just go watch for: morals, principles, ethical values, and scope of practice. We'll touch on some of these areas. Next slide. So I want to take a little bit of time and look at, and Kate, I'm wondering if, I'm not seeing my notes section here, and I'm wondering how I access my notes section. Is that going to be something that I'll have to probably do? Maybe I think I can pull this up.
Do you have it open on your own computer? Because I can see if I can change my view so that it shows notes.
Let me just hold on, everyone. I'm going to see if I can't pull up. I pulled this off my desktop and want to see if I can. Where did I put that? Oh boy. There we go. I got it.
Okay.
Yeah, I've got it. Yeah, this is fantastic. So it's modern technology at work, folks. So yeah, let's go back to. We can, as long as you guys can see the screen, I think that's the important part. And I want to look at we're talking about the principles of effective treatment, and I think this is really important. I think I want to make sure that we understand some things as we get moving through some of these principles. Obviously, we know this. Substance use disorders are a complex but treatable disease that affects brain function and behavior. Now, I want to say that my own clinical experience, I have strong evidence that's supported both empirically, but from my own clinical experience, people can and do recover from substance use disorders. We know this. I think it's also important to keep in mind that no single treatment is appropriate for everyone. I think about this notion or this idea that one pathway or approaching treating substance use disorders is something that we need to understand, that there are multiple pathways to achieving this.
I just joined a Zoom thing and I can't hear it. I can't hear it.
There's no single treatment that's appropriate for everyone. So There may be common themes that we see or particular approaches or programs that work better for some than others, really depending on a variety of factors. You can think of, can any of you think of any examples? Things that I might consider or look at when I'm looking at a treatment approach is readiness to change, the presence of co-occurring disorders, gender, ethnicity, trauma history, etc. There are multiple things to consider. And then I think we also need to look at various types of treatment needed to be, they need to be readily available. So addressing issues pertaining to mental health, relationships, gambling, legal issues, child custody, parenting issues, medical substance use issues, medicated assisted treatment. These are just some things that we need to look at as far as whether or not these services or these types of treatment are available to the patient. Also looking at effective treatment that tends to multiple needs of the individual. So again, I would want to look at this under this sort of biopsychosocial umbrella and treating the whole patient, not just their substance use. And I know that some of you who have been on webinars with me before know that one of the bases to my treatment approach and working with patients is understanding that their substance use is symptomatic rather than the problem. In other words, their substance use is symptomatic to some other underlying or co-occurring issues that are driving that substance use. I hope that makes sense. Also, remaining in treatment for an adequate period of time. This is critical, and what we're talking about here obviously is length of stay. And length of stay, as we know, can be determined and driven by many factors, and sometimes it's resources or insurance coverage or programs that are really driven more by the curriculum rather than the progress of the patient. So some things to keep in mind. Let's go next slide, Kate. Also, I want us to keep in mind when we're thinking about the principles of effective treatment, think about behavioral therapies. Behavioral therapies are the most commonly used forms of substance use disorder treatment. Again, I think that's something that many of you may already be aware of, but it's something that we know is supported through evidence-based practice, and it's extremely important to understand that. Also, that medications or pharmaceutical interventions can and are an important element in the treatment for many patients that we see. And there are still those that are not as accepting of this principle, but I know there are still treatment centers that require a patient to stop all medications before they're allowed to participate or attend treatment programming. But more so now, we see that medications are just part of the milieu or part of that treatment service delivery or continuum, and it's more the norm now than it is the exception. Also, an individual's treatment plan must be continually assessed and modified. So I think that's important. Think of the treatment plan or the comprehensive treatment plan or whatever title or term you use at your agency. Think of this as a living document. What does that mean? I think if we were in a live setting, I think we would brainstorm a bit and try and come up with some ideas. But a living document means that it's not a one and done. It continues to be edited and updated depending on the patient's progress and need. So think of that treatment plan as a living document. Also, an individual with substance use disorders may also have underlying co-occurring issues, including mental health diagnoses or disorder. I think that this is also extremely important. There are studies out there suggesting that as many as 2 out of 3 patients may have a co-occurring or comorbid disorder of some kind underlying their substance use disorder. And I would argue that it may be, even more than that. If we think about the human condition, issues like grief and loss and trauma are really intrinsic parts of being human. And again, I want you to think of this when we think about a person's alcohol or drug use as symptomatic rather than the problem. And the problem really are these underlying issues. So really important to keep that in mind. And then also, detox is only the first stage of substance use disorder treatment. Well, what do we mean by that? Well, it may be the first stage, but it is absolutely a vital stage in many cases when there is acute or moderate or severe dependence issues present, especially with drugs, certain drug classes. And I would say alcohol being probably the most glaring because alcohol withdrawal detoxification complications can be life-threatening, as most of you know. So think of this, though, as really, think of it as stabilizing not just the body, because I think we think about detox as stabilizing the body, but think about it as treating the brain as an organ, and that organ has been compromised. And until we treat the brain disorder and let the body recalibrate properly in a detox setting, progress along the addiction continuum, that substance use disorder continuum and treatment may be almost impossible. So detox is really the first stage, and I would say really detoxing someone from a drug like alcohol is very black and white. You can put them on benzodiazepine taper, and they will respond to that, and the body will recalibrate and adjust to the lack of the presence of alcohol. But it is really the first stage, and really probably the easiest stage, because what comes next is the psychological, addressing the psychological and emotional issues. Next slide. So there's some other principles that I want you to keep in mind as well. Treatment does not need to be voluntary to be effective. And I think when I first saw that or heard this, I thought, well, that doesn't make sense. If someone's not voluntarily engaged in treatment services, how can they gain or benefit anything? And the research really indicates that mandated treatment versus voluntary treatment, the outcomes are about the same. And those of you that have practiced enough know that sometimes having a patient who is mandated into services can be much more straightforward. You can really collaborate with them. For example, I might say, well, let's show your probation officer that you can do this and make some changes, even if they're temporary. Let's show them. Whereas someone who comes in as a self-referral, they may really have some ambivalence about whether they want to engage or stay engaged, whereas a mandated patient may be They may not have the choice up front, although I would often tell even mandated patients, you have a choice. You're choosing to be here and making an informed decision about the alternative to not being here. But I think it's important to know that voluntary versus involuntary treatment engagement, the outcomes, in other words, how they do after the treatment is over, those outcomes are about the same. Something else to keep in mind, during or drug use during treatment must be monitored continuously as lapses occur. And I think this is really important too. This has got to be handled, I would say this needs to be handled with some clinical consistency and objective considerations. Most treatment centers, as you know, most treatment centers are abstinence-based. Thus, continued use of alcohol and other drugs may require an increase in level of care and or may involve more serious consequences if a third-party referral is involved. But I think it's important. We collected a lot of urine samples at the clinic. In fact, I would often say that I collected gallons of urine in my career. So I just want you to imagine this. There were only 30 milliliters at a time, but a person's continued use during treatment is an opportunity as well to address difficulties or struggles they may be having with making the choices to initiate or maintain change. Also, patients should be tested for HIV, hepatitis B, tuberculosis, and other infectious diseases, as well as targeted risk reduction counseling, linking patients to treatment if necessary. And again, I think this is, again, part of the norm. It really has become part of the vernacular and is built into many treatment facilities and their protocols now. And this is not only good patient care, but often it's state, local and state government mandated because it can pose an overall risk to public health and well-being of the community as well as other patients. Next slide. So let's look at, I want to look at, again, just some key words to look at as we continue to move through our discussion today. Foundations. So just think of some of these words just to help kind of key in on them. So think about professional and ethical responsibilities. Think about the vocabulary that we utilize, values, morals, and perspectives. Distinction between legal and ethical dilemmas. We're going to touch on that. And then also some ethical values. So keep those in mind as we move forward. Let's go to the next slide. So the term scope of practice is something that I know probably many of you have had some exposure to or understanding of in the past. Scope of practice, think of it as general counseling theories and treatment methods. So where your training lies, where your credentialing lies, where your educational background lies. Think of it also in terms of screening tools, assessments, evaluations, and diagnosis. Think of scope of practice within the context of treatment planning and case management. Think of scope of practice as individual, group, and family or couples counseling. And then also think of scope of practice in terms of patient, family, and community education. Next slide. So one of the things I want us to have a clear sort of separation from or understanding of and discern between the two is legal and ethical dilemmas. Though they are connected in many ways, they also are have their own sort of set of guidelines. So ethical dilemmas really are aspirational. They concern professional practices and standards. If not self-monitored regularly, agencies can step in. Safeguard autonomy of professional workers. They're dynamic and evolving, and often they're a matter of opinion and not always a legal concern. And we could spend an afternoon talking about various ethical dilemmas that we're faced almost on a daily basis in our clinical practice, as well as in our personal lives. Legal dilemmas, on the other hand, I think it's important to understand them as being determined by federal or state guidelines or statutes. Also, they involve corrective measures and an effort to police the profession for some oversight. They may involve litigious or legal fears versus professional integrity. They are implemented if ethics are consistently violated, and they may involve civil or criminal law, and they may also enforce sets of precedents or protocols from previous or pre-existing cases or previous cases from the past. So I just want us to create a distinction between the two. There is some overlap and they are connected, but they're distinctly different. Next slide. I think it's important that we understand the duty to warn. The Tarasoff versus Regents of the University of California, 1976. We're going to circle back to this in a minute, but duty to warn was established really to protect others from threats to self or others, protect them from harm. And we're going to circle back to this this duty to warn concept and talk about it a little bit more. Next slide. So, and those of you that I guess we could back up a minute. Those of you that don't know, I shouldn't assume everyone knows, but the Tarasoff decision, this relates to a court decision, and has meant that if a person is in danger from a person with mental health or behavioral health issues, the clinician has a duty to warn. This decision means that the therapist must tell the authorities if a patient is a danger to another person. That's essentially, it's a very simplified explanation. So, okay, let's keep going. So, ethical values. So just, in a nutshell, when I think about these, I think of it in this way: be good, do good, and above all, do no harm. Very simple. That can really be sort of the guiding force behind ethical values in practice. Next slide. So I want us to look briefly at some professional and ethical responsibilities. And again, these may be review for many of you. And so I think if we're in a live setting, we might have a little more discussion about some of these and some of your own experiences. But I'm going to go through these, and I have a few comments on some of them, but we're not going to spend a lot of time just due to our time constraints. But the first one, adhere to established professional codes of ethics. And I think we all, depending on the discipline or the field that you're in, Each discipline can have their own code of ethics, but the guidelines are there for you to follow, whether you're in social work, nursing, substance abuse, or mental health fields. They're there, and they act as a guiding force. 2, adhere to federal and state laws and agency regulations. I think, again, that is extremely important and pretty obvious, but very important nonetheless. And then to interpret and apply this information. And I think that is also a little easier to do, I would say, in a clinical setting where you have staff and other staff and colleagues to work with. Sometimes it can be a little tricky when you're in a private practice or working independently. Next slide. Number 4, recognize the importance of individual differences. And again, I think this is pretty self-explanatory, so I'm not going to go into that too far, but I think it's something that I think many of us who get into the field, this is an inherent part of our own ethical and moral sort of compass. It's built in for many of us that get into the field to try and help others. I think number 5 is also often overlooked, but I think when we talk about professional and ethical responsibilities, to utilize a multitude or a range of supervisory options. Your supervisor really, is a resource for you to use when faced with ethical decision making, whether this is a routine or significant event. Your supervisor or manager will likely have some experience and or precedence to assist you in making the right call. And if they don't, then we would take that to the next level and go from there. I would often say to my staff, if they came to me with a dilemma or a situation and they kind of stumped me with something, I wanted to give them a prize, because then we had to go to my supervisor and process this. But your supervisor can be a really, really great resource. Conducting self-evaluations, I think this can come in the form of either performance evaluations or doing some self-evaluations outside of the scope of your required work environment. Next slide. Number 7, I think many of us, for example, today, I'm hoping that those of you that would like to have 1.5 continuing education credits, that we would be able to provide that to you. But continuing your professional education, I think about the ethics trainings that can provide some foundational components to a new clinician who's just entering the field, or vital review for the experienced clinician. I know in Iowa, we require, the certification requirements require that we receive so many hours of ethics each recertification cycle. So it's important. I think this can also be important surrounding matters of mandatory reporting or child abuse issues. Number 8, participating in ongoing supervision. Now this, I think, I would suggest weekly or bi-weekly supervision in a clinical setting. Private practice can be a little more challenging if you're working independently or in a small group of practitioners. But find a colleague or a mentor. It's your responsibility to maintain a level of ethical and professional readiness. And then maintaining one's own physical and mental health. This is sort of connected to number 8, but self-care, I know it's kind of it's kind of a worn out word these days, but self-care is absolutely essential. your family, your colleagues, and your patients will benefit the most from practicing self-care. Next slide. So this is just a link that I wanted to put up there. It's the Code of Ethics for Alcohol and Drug Counselors through NADAC. Some of you probably already have access to this, but it will refer to individual state-specific codes of ethics. NADAC is national, but certainly that's a link worth checking out if you're new to the field. Or to ask your supervisor or manager about the code of ethics for alcohol and drug clinicians. Next slide. So,
Sorry about that. I think I accidentally clicked on the link instead of going
oh,
to
the link. You're going to the link.
Yeah.
You were going to check out that code of ethics. I got Kate's interest already. So again, we're not going to have time to do. I think if we were in a live setting, I might ask for examples, but many of these are fairly self-explanatory. But code of ethics examples for alcohol and drug counselors. Responsibility to patients, dual relationships. I think these can be tricky in small communities. And I know that I've talked to others in Native American communities where you may end up working with a family member. One of the things that we often would do in situations where we knew this person personally, or there was what we would call a conflict of interest, is to do our part in reassigning them to a different clinician to remove that conflict of interest. Confidentiality is extremely important. We're gonna talk a little bit more about confidentiality a little bit later on. Professional competence and integrity. Again, this has to do with when I think about this. One of the things that comes to mind is impaired professionals, and also clinicians who are practicing without proper credentials or educational requirements. That's not to say that someone who's not credentialed or does not have an educational backing cannot be an effective clinician, but it's important for the field for us to have some standards. But an impaired professional, I think, is also something that is very concerning. There are implements in place to assist clinicians who are impaired or practicing impaired, either through substance use or other issues. Responsibility to students, employees, and supervisees. Again, due to time constraints, I'm not going to go into a lot of examples on these. Responsibility to the profession itself. Financial arrangements. This is one that can be difficult. Sometimes it's hard to talk about finances or money or lack thereof, but it's important to talk about it. And just like valuing saving for a car or taking responsibility financially, adolescents can be a little trickier because oftentimes they're not in charge of their finances. It's through the parent or guardian. But I think it's important to address financial arrangements before we provide services so that the patient is not being compromised fiscally in some way. Advertising, I think, again, this is, we need to think about utilizing evidence-based practices and curricula and utilizing that in our advertising for the approaches that we're taking as a treatment center. And then just legal and moral standards and following those to the best of your ability. and asking yourself, do my ethical responsibilities as a substance use or substance abuse counselor, do they stop as I walk out the door into the clinic? I had a clinician once years ago who was bartending part-time in the evenings, and would on occasion end up serving a patient or a former patient. And it was definitely something that we had to look at as an ethical dilemma. And she ended up finding a different job because it caused quite a conflict of interest to serve patients alcohol that she knew were either in treatment services at the time or actively relapsing. That's one example that comes to mind. Next slide. So let's just look at agency ethics. So this is something I've talked quite a bit about in the past with other audiences. Disclosure of personal recovery, mandatory reporting, acceptable practices, and culturally appropriate practices. There's a question that would come up oftentimes at our clinic where the patient would say, "Are you in recovery?" This question can be a slippery slope for a lot of clinicians. In the past, many substance abuse counselors were by default in recovery themselves. That was sort of what made up our profession, decades ago. The field has evolved over the past 30 years, though, and this has changed. However, disclosure of one's recovery can be beneficial to the patient if done appropriately. Yet this must be given careful consideration and done with the patient's best interest in mind. So it's something, the clinic that I worked for, we were prohibited from sharing recovery status with our patients. And I understood why, and different agencies have different policies, but it made it difficult at times to connect with patients, but it was not impossible. And again, when the staff at our clinic was made up of a mix of both recovery and non-recovery patients, we really wanted to avoid dissension among staff and patients, where if I disclosed that I was in recovery to a patient, then they might turn around and say, "Well, I'm only going to talk to Steve about these issues, and I'm not going to talk to Nancy because she's not in recovery and she won't understand this. She won't understand me." I hope that makes sense. But again, reviewing your agency's policies regarding self-disclosure may also be a decisive factor in your willingness and or ability to disclose your recovery experiences with your patient or patients. And lastly, we're also seeing a resurgence of peer recovery coaching and peer recovery supports. And these peer recovery counselors are being open and forthcoming about their own recovery. So we may see that become more acceptable and more the norm in the decades to come. Mandatory reporting, clearly there are clear state guidelines for this. So that's something that the agency itself oftentimes is required to have mandatory reporting trainings. I think our agency was every 5 years you had to go through I think it was a 3-hour mandatory reporting training. Just what are acceptable practices within your agency and what are culturally appropriate practices within your agency's code of ethics. Next slide. As far as ethical complaints go, know that your state has specific procedures for filing and processing grievances or complaints about ethical violations. I just listed a few here. I don't think these are links, but they're just some examples of different entities in Iowa for filing ethical reports of ethical violation or grievance. I just wanted to put those up as an example. Let's talk. Let's go next slide. Let's talk about patient rights, and I think this is also important. Next slide. So patient rights include non-discrimination, confidentiality, responsibility and competence, and informed consent. Next slide. Non-discrimination. So again, this is a review for many of us, but do not discriminate. Just examples: race, age, gender, etc. Any form of discrimination is simply not acceptable. Avoid personal issues. Be knowledgeable about special accommodations. And think ADA, think about making special accommodations for patients or coworkers. Next slide. Confidentiality. This, to me, in the substance use disorder field, confidentiality is sort of the golden chalice. It is the shield by which we protect our patients from being ostracized, misunderstood, stigmatized, and left out. So confidentiality is extremely important. Consent and confidentiality information. Your agency should have established regulatory forms and be compliant in this area. Patients' confidentiality rights include the Health Insurance Portability and Accountability Act, and of course, particularly those of us in the substance use disorder field, 42 CFR. I did want to note, part 2, I did want to note too, I don't know if any of you know, but there have been some revisions made to 42 CFR, and I did put the link up there. They're not extensive. They're really, no, they're not huge changes. They're more just some hybrid adjustments, in my opinion. But it's worth looking at. It's worth looking at and being aware of some adjustments to 42 CFR, the federal confidentiality regulations. And then making appropriate provisions as well should be noted under confidentiality. Next slide. Again, confidentiality continued, adhering to federal and state confidentiality laws. Know the expectations to the 42 CFR. Know what they are. And more importantly, know how to respond to law enforcement or other requests from other entities regarding requests for information. Present only the necessary data if you have proper consents in place. I would say, if any, does anyone know? Can anyone put in the chat box what's an exception to where we would be able to breach a patient's confidentiality? What would be an exception? Yes, there. Barbara's got it. Medical emergency. That's one I had on my list. What's another one that's important that we sometimes forget? Yeah, I would say yes, Antonia. That's true. Yeah, Valerie, the court order can be that's something to think about. Subpoena does not necessarily compel you to breach a patient's confidentiality or provide records. It oftentimes ends that way, but it's something that should be reviewed with your administration or your supervisor. Yeah, the one I think about is audits or record reviews. That's one that I often overlook. And then the other one is when there's a crime committed. When a patient commits a crime, they forfeit their rights to confidentiality, and I think that's important to remember as well. Okay, let's go to next slide. confidentiality and HIPAA and 42 CFR Part 2. The general rule, except under certain specified conditions, both HIPAA and 42 CFR laws prohibit the use and disclosure of records or other patient-related information. And you can read about this and look at this at the Legal Action Center. I pulled that information from their website on some data that they posted in 2003 pertaining to this topic. Hold on 1 minute. I'm just gonna... Sorry about that. A little background noise there. Let's go next slide, please. So I got to start using more polling questions, Kate, or some quiz questions. But let's do a quiz. Let's do an old-fashioned quiz here. Here's the situation. A treatment counselor is contacted by a patient's medical doctor who's interested in obtaining information about the patient's progress. The patient is given permission to release information. The counselor should. What do we think? Which one makes the most sense? Give the doctor a copy of the patient's entire file. Give the doctor only the information that is requested. Refuse to release the information due to confidentiality requirements. Set up a meeting with the patient and the doctor. Ask the patient to give the information directly to the doctor. Okay, we've got some responses coming in. Remember, the patient is given consent. Yes. Yes. Next slide, and we'll get the answer. Yeah, you guys, most of you guys are right on. So you're going to give the physician only the information requested. So these can be tricky sometimes. I know our consents, as many agencies have, there are specific itemized checks on those ROIs, those releases of information, where only certain or specific information can be released. Yeah, I don't disagree with you, Belinda. I think checking with the patient to make sure that that's the information that you're going to send or release to the physician. A lot of times too now with electronic health records, it can be a little more complicated as well because often records are all sort of lumped in one place or in one electronic file rather than the old paper files. Next slide. So let's talk a little bit about responsibility. And responsibility will include policies and management, assist others with knowledge acquisition, and then the reporting of any unethical behavior when you are a party to that or see that, but reporting that to the proper authorities. Next slide. Competence. Again, we're talking about ongoing education, so continuing to attend trainings, continuing whether they're external or internal. I know at the clinic that I was employed for many years, we had internal trainings 2 times a month where a staff person might present, or we would have a guest speaker come in and they would present on a topic or a specific training internally, or having your agency support external trainings as well, where you can go and maybe learn more about a new topic or a new treatment approach, or perhaps refresh on something that you have been practicing for some time. Boundaries and limitations, and professional competence and integrity. We're going to talk about we'll talk about some boundaries, boundary issues and things here in a moment. But I think what I would ask you to ask yourselves, maybe today or after we're done, is what areas do you need to work on towards your own competence in your profession, and reviewing those with your supervisor or manager, and incorporating those into your professional goals for the year. I think that's a great way to highlight and look at those. Next slide. Well, here again, some ethical principles, and these were pulled from a few different sources. But I think it's important to keep some of these notions or ideas in mind when we think about ethical principles. Autonomy. This, I think, is at the very heart of what it means to collaborate and empower your patients, allowing an individual the freedom of choice and action. Extremely important, and really can be absolutely vital in creating a meaningful and purposeful treatment experience for your patients. Non-maleficence, in other words, not causing harm to others. Above all, do no harm. Beneficence. This is the counselor's responsibility to contribute to the welfare of the patient, to do good. And I think that is absolutely those two working in tandem. If those are your driving ethical principles, you are practicing in a responsible and meaningful way. Justice. Treating this statement is a little confusing to me, but this idea of justice, I had this was from Kitchener's work in 1984, where he stated treating equals equally and unequals unequally, but in proportion to their relevant differences. And I'm still thinking about this, but essentially, if an individual is to be treated differently, the counselor needs to be able to offer a rationale that explains the necessity and appropriateness of treating the individual differently. And lastly, fidelity, loyalty, faithfulness. It involves this notion of loyalty, faithfulness, and honoring commitments. Patient must be able to trust the counselor. Otherwise, that therapeutic relationship may not be able to grow or move forward. So the counselor must take care not to threaten the therapeutic relationship or leave obligations unfulfilled. Next slide.
Can I?
Yeah, please.
There's been some chat. Somebody asked earlier, and this reminds me of, so Todd asked, are you saying that if a client commits a crime, for example, theft from their neighbor, they forfeit confidentiality? And Steve, go ahead and answer from your perspective too, but I know Bob Rarrett, our dear friend who has often taught this section, I know, remember him telling stories of his detox unit when often authorities would come there looking for someone who had, allegedly committed a crime, and he could not even confirm or deny whether that person was there without consent.
That's true, and I think maybe I need to clarify when we talk about a crime being committed or damage to property or an assault. This would be something that's occurring within the clinic. So if a patient were to assault another patient, or if a patient were I can think of a patient who stole the cell phone of a clinician, and we had to report that as a crime, a theft, and provide that patient's information because a crime had been committed on our property. If a patient commits a crime, previously or admits to this, that's not something we're obligated to report. If law enforcement or someone comes to the agency asking if a person is there, we simply cannot confirm or deny that they're present. Does that make sense? Yeah.
Is that you? No. I brought that glass thing and it's in my trunk, but I wasn't sure if you wanted to transfer it. Sure.
So and there are other factors to consider as well, but exceptions. The exceptions sometimes are contextually bound. So when I said a crime being committed, I was thinking more of on the agency property. Does that make sense? I hope I answered that.
I have
past
a
crimes.
story related to duty to warn, if it feels appropriate to share that now, Steve. When I was working with someone who she was warned by authorities because a former partner had made a threat of harm for her towards her, and so in that case, this person's mental health professional had warned the authorities so that they could warn my colleague, and then thankfully she also warned me because this person knew where she worked and I was a front office employee there, and so I was really appreciative of her doing that because obviously there's sometimes some stigma attached to her relationship with this person, and but she knew that I could be in danger, and so she let me know that he was off medication and had a weapon, and so we were able to come up with a plan so that everyone felt safe, until he was found, until his location was known. And so that was an instance where I think his confidentiality just in his current mental state was shared with a few of us who were in a potentially dangerous situation.
Yeah. Well, thanks for sharing that. And I think there are always going to be dilemmas that come up where we need to look at the situation and place it in that context. And one of the things that I took a lot of comfort in was knowing that I did not have to make that decision alone, and that I could consult with a supervisor or colleague, perhaps with more experience, and learn from that and really help set the precedents and follow the letter of the law, as well as the agency's policies and procedures. So it's important to not feel like you have to make the decision, on the spot, although there are times where you're required to make a decision pretty quickly. Consult with a colleague, consult with a supervisor. I can remember a time when we had a patient, a committal patient, that kept absconding from our property. And this isn't directly related to confidentiality, but it's related more to sort of patient safety, and it was an ethical concern about his safety because he kept taking off and running away. And I was really concerned that he was going to injure himself or someone else. And the sheriff kept bringing him back. The deputy kept bringing him back. And the third time he brought him back, I said, I really think we should probably secure him because we're not a locked facility. We don't restrain or isolate patients, and I'm concerned for his safety. And the sheriff said, if you don't take him, I'm going to hold you in contempt and take you to jail. And the sheriff was under a civil committal court order to have this patient at our facility. Yet I couldn't keep him safe, and we ended up working it out with our medical director. But I thought I was going to be in an orange jumpsuit there for a minute. I got a little worried. But I think each situation can differ. What doesn't change is the ethical principles that guide us, and some of the laws and some of the legalities connected to confidentiality. Those are set and hold little in the way of interpretation. So rely on colleagues and supervisors to help you make some of these decisions. I hope that makes sense. I wish we could expand on this more, but I don't want to run us out of time. I'm notorious for that. But thanks for your comments, Kate, and others. I see a lot of great comments in the chat box. Okay, let's go to the next slide. Really important that we talk about boundary setting. Again, I think this is something that we think about the nature of our work. We are connecting with patients, collaborating with patients that are sometimes extremely vulnerable and really in need of support and guidance. And it's absolutely essential that we maintain boundaries so that we can not only promote safety and integrity in our work with them, but that they can also feel safe and protected, and that we can maintain our objectivity in working with them. Next slide. And again, we'll go back to the notion of doing no harm. This non-maleficence, it can be a guiding factor in establishing and maintaining boundaries. Couple of terms that we see sometimes come up, and I would encourage you, if you are feeling some transference or countertransference, that you talk with your supervisor or colleague about how to address this matter so that it does not interfere with the patient's experience and your work with them. Let's go to the next slide. So some issues surrounding or connected to establishing boundaries. We mentioned this earlier, but dual relationships. Sometimes these can be subtle, and sometimes they can be blatant. But we need to be very careful about maintaining or avoiding the dual relationship. I've had patients in the past where I encountered them in their work setting. I had one patient that ended up doing an oil change on my car, and it wasn't something planned, but these kind of things happen. Dual relationships can significantly impair and impact your ability to maintain some ethical integrity and continue having and working with patients. Sexual and affectionate feelings versus behaviors, something to keep in mind. And this idea of bartering for services or providing services in exchange for something else. Again, this is ethics 101, but I think it's really important, and there can sometimes be, in different settings, this may be something that is deemed acceptable, or something that is seen as okay or justified in some way. So you have to be really careful. Consult with your colleagues, your supervisor, and your agency's policies, and protocols, but moreover, look and refer to your ethical codes. It makes it very clear to avoid bartering or exchanging services or quid pro quo. Next slide. Mandatory reporting. Again, I think that we mentioned the Tarasov case, the duty to warn, but I also think there are very specific mandates and protocols for reporting child abuse or any kind of sexual misconduct of a therapist where there are improprieties taking place that are clearly where there's an ethical violation going on, and perhaps even criminal or legal violations to consider. Very, very important. Mandatory reporting should be part of the vernacular at any agency. And if you're not in an agency and working in a private practice, you need to take it upon yourself to know what these protocols are and what your obligations are. Iowa is a mandatory reporting state, so we are compelled to report. I'm sure that other states have similar mandates. All right, next slide. The utilization of supervision. Boy, I can't tell you how important this is. It's especially if you're just coming into the field, but even if you've been practicing for a while, really important to have a supervisory relationship that you can, run recommendations by, discuss patient difficult or challenging patients, professional development, addressing even personal matters or self-care issues. But think of it really as opportunities to test concepts, different practices or techniques. Again, reviewing recommendations or diagnostic information about a patient to get a second view or another set of eyes. And then administrative, clinical, and evaluative supervision. All of these are absolutely vital in having a meaningful connection with your supervisor or manager. So yeah. From a clinical perspective, good supervision can really help you learn broader scopes of practice and really help you to develop professionally what kind of counselor or clinician you want to be. Okay, I think we're getting close here. Next slide, Kate. So just a sort of just a summation of our review today. Key points to remember. Aside from these, I want you to, if you're working with patients with substance use disorders, please think of their substance use as symptomatic and really use that as an opportunity to explore with them why they started using in the first place. I would often ask my patients to tell me what it is they liked about alcohol or what it is they liked about cannabis, to give me some insight and to help me understand. I wasn't condoning their use, but I certainly wasn't condemning it. Trying to understand what their ground zero moment was, whether it was adverse childhood experiences or recent trauma, grief, or loss. These themes would come up again and again and again with my patients, and I knew that those were the driving factors behind their substance use. And really the key to addressing that is to provide a viable alternative to help them work through and attach meaning and purpose to their underlying issues. Other things, though, to remember, be good, do good, and above all else, do no harm. That maleficence and beneficence are driving factors. Distinguish among ethics, morals, and legalities. If anyone says that they don't let their values or their morals influence the work they do with patients, they're not being honest with you. It's very difficult to sometimes set aside your own values or your own cultural perspectives and not let them influence your work even indirectly. Also, patients' rights are always foremost. So the patient must be protected at all costs. Also, your ethics can greatly impact the quality of the patient care and the image of our profession. And boundary issues really start with, can often start with just small innocent transgressions. Even something as simple as offering a ride to a patient. There have always been exceptions. I remember I had a youth show up once, and by the time we were done with our session, it was pouring rain. I mean, just pouring. And we ended up making a rain suit out of a couple trash bags so that he could make it home and stay relatively dry. Now, that was my alternative to saying, you get in the car and I'll drive you home. It can start as something as innocent as that. Really need to be careful. Boundary issues have to be established early and maintained, or we set ourselves up for trouble. I just included some references on the last couple of slides, and can show those, Kate, if we would like to. Certainly a copy of this can be provided, a PDF copy of this presentation today can be provided. I think we've got a few minutes if we want to. There's a lot going on in the chat. I wish I had a chance to stop and read some of this. But we've got a few minutes. Questions, and if you want to unmute and jump in there with an actual question using your voice, that's fine too.
There's been a lot of great discussion about.
I know.
Yeah, some people were just talking about boundary issues, and yeah, someone mentioned, trying to figure out how to best check up on clients who, especially during COVID, and somebody mentioned people weren't allowed to stay at the detox center once COVID started. And so, yeah, do people have other ideas of how can you ethically check on them while kind of upholding good boundaries, both for yourself and for your client?
Yeah, and I don't know if others, have had some experience with that. I have not been in a clinical setting during the COVID pandemic, but I think it's, I keep thinking we're all in this together, but we're all kind of apart. It's a very interesting dynamic, but I don't know if others have comments or want to unmute and share about that, that concept or idea, those of you that are practicing. Seeing some great comments here. Yeah, we've got. I don't know if I'm saying your name right. Is it Melindia? She says we utilize peer support to check in. It's like Melinda. Okay, got it. Thank you. Yeah, Melinda says they use peer support to check in during the COVID, and I think we've got technology at our fingertips to reach out and connect with patients. I do a lot of that in the recovery community myself on a personal level, just being able to reach out and text or call folks. It's really absolutely a game changer for some. Other questions? I'm trying to see if we've got other questions or comments. Yeah, a lot of comments about dual relationships. Confidentiality is a big, it's always a big topic for discussion. I would encourage you again to check out some of the changes made just recently, some of the adjustments and addendums made to 42 CFR. That's interesting, yeah. Anyone have any questions? Anything else we want to revisit? A couple more minutes.
Looks like Stefan might have had a question. He says, I have a question. We deal with boundaries in self-help groups. Some of our staff attend NA or AA, or maybe you mentioned AA. And what do you suggest? My personal stance is if you are working with clients in the professional setting, you are saying you will give up those meetings if it affects a client who would be going to meetings for aftercare in a negative dual relationship way.
Yeah. Yeah, is that, you said that was Jeff?
That was Stefan, I think.
Oh, Stefan. Yeah, Stefan, that's a great point. And I think it's something that has to be decided and discussed as an agency. And I know that was an issue as well here in our community where, and then there's the counter to that is, if a patient were to see me at a meeting, that I would be sort of demonstrating what it looks like to be a person in recovery and trying to do the right thing. And so there's two ways to look at that, but I definitely am acutely aware of, for years I avoided meetings because I didn't want to interfere or compromise the patient's attendance at those. So I understand there's certainly ways I like the idea of giving up a certain meeting and attending an alternative meeting that a patient is less likely to be attending. I appreciate your comments for sure. Well, Kate, do we see any other questions that popped up in the chat? I appreciate Sean Bear's comments, and really great to see Doc Foster and Rafaela and others that I see on some of our other events and broadcasts. So I hope everyone can stay safe and healthy, and we'll meet again here. I think we're going to try and do a follow-up to the treatment knowledge discussion we started a couple weeks ago, or was it last week? So maybe I'll catch you then. Otherwise, I think we'll conclude our broadcast today. If you haven't had a chance, please fill out the survey. It just takes a couple of minutes. It'll help us continue to provide these type of webinars and events and broadcasts at no cost. So again, thank you everyone, and for your time and attention. Have a great rest of the week. See you again.
Wonderful. Thanks so much, everyone. And yeah, put the link to our survey in the chat, and also a link to our storytelling session that will begin in about an hour and a half. So hope some of you can join us for that too. Thanks again.
I think a half an hour. I think that starts at a half an hour, Kate.
Oh, you're right. I'm sorry. Thank you.
2 p.m. Central. Yeah, we'll see you at the storytelling hour if you're interested. Okay. Take care, everybody.